Zach, thank you so much for joining us today. I'm excited to dive into today's topic of strategies for reducing falls in the ED, a topic I'm sure you're very familiar with.
Thanks. I'm really happy to be here and excited to talk about this because fall prevention in the emergency department is really crucial to saving patient lives, in addition to all the emergent things that we do. So what we're going to talk about today is to first distinguish between the different types of falls. We're going to discuss human and financial costs of falls. We're going to identify ED-specific risk factors for falls. We're going to discuss evidence-based fall prevention practices and how we can integrate some technology into fall and injury prevention practices. Then we have anticipated physiologic falls. These are the types of falls that are our bread and butter, and these are the ones we're going to focus most of our conversation on today. Falls that we strive to prevent by identifying those that are at risk and intervening to minimize that risk for these patients. There were over 36,000 adults aged 65 and above who died from fall-related causes, and over 3 million emergency department visits recorded for adult patient falls in 2020.
Wow.
45% of inpatient hospitalized patients are age 65 years and older. And guess where those patients are coming into the hospital from?
The ED?
Of course, from the emergency department. And that means that our patients in the emergency department are at a disproportional risk of death from a fall. And we know that that demographic is going to continue to grow over the next several years. So we've talked about the financial costs of falls, and you can see here that the average cost of an inpatient hospitalization for a fall is over $30,000. And what this adds up to for the national health system is over $50 billion annually. So falls really do have a high cost financially. And we also know that they have a physical and emotional cost to the patient. And I think lastly, the important piece to consider is the cost on us, the cost on our coworkers and our team members in the emergency department. We're such a close-knit group in the ED, and falls can even take a toll on the strongest team members. I imagine that many of us have had a patient fall at some point in our career. It is really vital to have the support of our team members and our nurse leaders to recognize that what can we do to prevent that fall from happening again, and how can we make sure that if there is a fall, that these patients are not injured. As I alluded to before, the emergency department has long been the gateway to the hospital, and that's increasingly so. More and more patients are coming into the hospital through the emergency department. And what that means is a lot of times they're waiting there longer. They're waiting there to transfer to inpatient units. They become boarders in the emergency department. And this means that now emergency departments are being scrutinized, and there's an increased focus on accountability for quality measures in the department. So once in the past, measured quality measures such as falls were really an inpatient concern, but they are now more and more becoming concerns of the emergency department. There's really two main things that we have to do. We have to do an accurate assessment of risk, and then we have to put in some prevention strategies. Those two things are going to allow us to create an ED fall prevention pathway. What's really important is that while we're all focused on decreasing left without being seen and working on our sepsis initiatives and stroke initiatives and trauma care and all these other things, fall prevention also has to be held to that same regard. When we look at developing fall prevention pathways, we also should include the staff. Anytime we have the ability to include the staff in projects, it allows them to be more engaged and allows them to buy into that process a lot easier. So when we're talking about implementing fall prevention pathways here in a moment, it's important that the staff are engaged and involved so that they can also feel comfortable to do those things that we're going to ask them to do here shortly. For fall risk assessment to work in the emergency department, just to summarize, it must be fast, it must be ED specific, it has to include toxication and sedation factors, because we do see a lot of those patients. It has to allow for nursing judgment, but not be exclusively reliant on it. And we also have to be able to do an accurate reassessment with changes in patient condition, or if we administer sedation medications or whatever the case may be, we have to be able to reassess it quickly. So what do good practical fall risk mitigation tactics look like in the ED? There's really three main things. The first is hourly rounding, and we can talk a little bit later about what that means. We can do fall risk icons, such as a falling star on the outside of the door. And then we should do fall bundles, whether that includes a colored bracelet or colored non-slip socks or stretcher alarms. Whatever those bundles are, those are the three big mitigation tactics that we can use to decrease falls. Really, when we do hourly rounding, we should focus on four things: whether the patient is in any pain, whether the patient has all their personal belongings with them, whether the patient needs to use the toilet, and then whether they're in a comfortable position in bed. Because a lot of times a patient is trying to address one of those 4 things when they attempt to get out of bed, and that leads to the fall. So if we can proactively and preemptively address those 4 things for the patient anytime we round every hour on them, it's going to decrease their need to try to get out of the bed, which is really going to keep them safe. So when we pulled the staff in to develop these fall prevention practices, we are engaging them to build this culture. What does fall prevention look like to them, and how do they feel that they can remain consistent with the practices that we recommend putting in place? The last is that we have to encourage effort and support by nursing leadership. Anytime we're making big process changes, or we're looking to buy new equipment, or to have things that keep patients safer, it's really important for us to make sure that our nursing leadership is supportive of it so that they can keep policies in line with everything that we're doing and make sure that our patients are remaining safe. So consider the ability for an electronic health record to analyze the patient's chief complaint, the vital signs, the medications, their recent encounters, and any of their health data, and then automatically determine an initial fall risk. Once it does that, it can suggest evidence-based interventions as part of a best practice advisory. That's significant ability to integrate technology and to standardize can be really important for making sure that the care we provide is consistent no matter what staff is on, what providers are on, or who's working in the emergency department. And that is really going to allow us to make sure that these patients are kept safe. So stretcher technology has to be considered one of the primary pieces of a multifaceted approach to fall prevention. Anytime we can integrate patient movement monitoring, bed exit alarms, and patient motion lockouts, those are great ways to keep patients safe, and stretchers can do that. Another way to enhance patient safety is to use proper positioning while on the stretcher. So the side rails should be up, as we mentioned before. They provide physical barriers for patients that are at high fall risk. The brakes should be set, the proper exit alarm zone should be activated, and the stretcher should be at a low height. When we integrate these technologies into the stretcher, it really allows us to utilize fall prevention strategy that's at the fingertips of the care team.
That makes me think of like travel nurses and onboarding new nurses. When there is a difference in stretchers, that education and that onboarding process probably takes a little bit longer than if the facility was completely standardized.
New bed exit alarms can cater to the care needs of each patient. So some technology allows for multiple zones of sensitivity depending on those unique needs, and this flexibility can reduce alarm fatigue. If every time the patient squirmed in bed just to reposition themselves, the alarm went off, we would have a lot of alarm fatigue. So sensitivity is really important, and having multiple zones as options is really important for us. So what they did is they developed a task force. They completed an ED gap analysis and a retrospective review. They developed a comprehensive falls program that included an ED-specific fall assessment tool, remote video monitoring, stretcher alarms, and then they really embraced that patient safety culture with their staff. And in a 2-year period, they saw a decrease of 27% in adult patient falls and a 66% decrease in falls with injury.
Thank you for watching this webinar preview. My name is Julie Cullen, the Managing Editor of American Nurse Journal. I invite you to watch the full version of this free on-demand webinar. Just follow the link in the description. You can also visit myamericannurse.com for a full collection of our free educational webinars. Thank you.